Well, good evening, everyone. We're going to go ahead and get started this evening. If we have anybody to come in late, we will make sure they get to the right place. I'm Matt Jordan. I'm the senior pastor here, and just want to share a word of thanks to all of you for being here tonight, especially our guests. Gene Johnson's going to come up in just a moment before we introduce Dr. Jordan, but we are beginning a new ministry here at First Methodist Church called Respite Care at First Methodist, and this is kind of a first step in that process. We all know that Alzheimer's and dementia are unfortunate realities of life, and being able to navigate those things are difficult, and being able to express those things can also be difficult. So I do want to give a few housekeeping things for you. One, the restrooms are to my left, to your right. If you've never been on our campus before, through this door you'll turn right. Through that door you'll turn left. It just goes right along this wall. The second thing that I'll share with you as well is this will be live streamed, just in case folks could not be here tonight. What that means is if you decide to take off your clothes and run around the place, it's going on Facebook and YouTube, and it'll be permanent there, okay? It also means that if you ask a question, what we would love, and I know Dr. Jordan, being a great presenter, will probably repeat that question. But if you could raise your hand, and I'm gonna put Jean to work. You don't know, Jean got licensed as a local pastor at our church yesterday, so now we can officially put her to work. But if you have a question, raise your hand, and Jean will grab this mic. Dr. Jordan's going to have a lapel on, and she will take this mic to you, just so those that may be watching online can hear the question. It doesn't pick up the audio in the room; it just goes through the sound system. So, and it may, you may say this is silly to have a mic in a room this size or this small. And listen, I'm just telling you, we have a few of our church members that put recorders on right in front of the pulpit on Sunday morning so they can hear in their hearing aids. So we want to make sure that everybody has a chance to hear the question because those are valuable and great ways for us to learn. But again, if you need the restrooms, they're along this wall here. And if you have a question during the presentation or at a time when Dr. Jordan allows those questions, raise your hand. Jean knows how to work a mic, and she will bring it to you just to make sure that we can get that on the live stream for anybody that may be watching, okay? Anybody have any questions for me? And this, don't worry about this being on the live stream, but anybody got any questions for me before we introduce Jean and Beverly and go forward? Wonderful. That's the kind of questions I like. Great. All right. Dr. Jean Johnson is our current respite care director, and she's going to come and share a few words about that, and then we will introduce Dr. Jordan. Jean?
Hey, everybody. We're just so glad to have you here. This is an informational meeting. It's really not so much about training for respite as it is understanding what we're dealing with as a society, which is rising numbers with Alzheimer's and other related dementias. So you're here to learn. I'm here to learn, and I'm very excited that we have the opportunity to have our guest, Dr. Jordan. We are going to start a respite ministry. The start date is now September the 9th, which is a Tuesday. We'll run Tuesday and Thursday, and we will serve our participants, or our friends as we call them, from 10 to 2. This gives their caregiver a nice break in the middle of the day to do errands or rest or whatever they need to do. Some of you may be in that situation as caregivers. I certainly have been, and I understand how you feel. So it's a break for the caregivers. It's going to be a wonderful party-like atmosphere for our friends with dementia. We'll have all kinds of activities to do and songs to sing and exercises and dance and games. A lot of things are going to tire us out, probably tire them out. They'll sleep well that night. But we're excited, but it's really more about the information today. And if you have any questions, or if you know anyone that needs my card and number, just catch me afterward. And right now I'd like to introduce Dr. Beverly Jordan. We're so glad to have you.
Thank you, thank you. All right, so we're going to talk about dementia. I'm used to being interrupted all day long, over and over and over again, so ask whatever questions whenever you want to, but we will have time at the end for questions. So, Matt's running as hard as he can. We can go to the next slide. I just have to have a title slide hard. So we're going to talk about Alzheimer's is a type of dementia. So there are lots of types of dementia. Alzheimer's is the most common type of dementia. We're going to talk about the different types. You can go to the next one. Types of dementia there for just a second. So how we get the diagnosis of dementia. So we have to have significant cognitive impairment in one or more domains. So what are domains? Learning and memory, language, executive function, complex attention, perceptual motor function, or social cognition. So this is where you have to know the person to figure out if they have a decline, right? So, I always tell this story. So back, one of the things that I do is sports medicine, and so for years I worked with the University of Alabama, and we would do concussion testing. And so you would think that it would be relatively easy to do concussion testing with college athletes, because most people believe that college athletes are not the most intelligent humans that roam around. But some of them are rather smart. And so we did this really basic testing when they had an injury and we were worried about their memory. And I had this kid, I asked him some basic questions, and those questions involved doing math in your head. And he could do the answers faster than I could. So I finally stopped and said, "Hey, what's your major?" Chemical engineering. I said, "Okay, got to get some new questions. Hold on just a minute. We're going to ask some different questions." Well, that's also pertinent in dementia, right? So you take a professor, you take someone who taught for a living at a very high level, reads a lot, and it can be very difficult for a physician who sees that person once for 15 minutes twice a year to see the decline that a family member can see. And so understanding that baseline is very important. But we need to lose something in those areas or domains of cognition, which also include social cognition, so not knowing how to behave appropriately in a social context, not like my teenager, but somebody who learned it before and now can no longer do it anymore. They know better, but they cannot do it anymore. So lots of areas in which you can see that decline, and it's really important as a family member or a caregiver to notice those things early, because there are real opportunities to intervene early, and people tend to really be embarrassed by the loss of memory or the loss of function, and so they don't say anything, or maybe a lot of times I see where it's an argument, right? We come in and the husband needs to say that the wife is not doing well, and there's a fight. And so you know that they leave unhappy with one another because somebody brought this up, or the children come in. It's always difficult, but I promise you it is worth the fight, because there is lots that can be done if we intervene early. So that impairment has to be acquired, okay? It has to happen at some point, and it has to be a decline from previous function. All right, so we're not talking about I never gained this skill and here I am, and just because I'm above the age of 65 and I don't have this skill, now I have a diagnosis of dementia. We are talking about a skill that you had that you lost. It has to interfere with your independence. So this decline has to keep the patient from being able to do what we call activities of daily living. So what are activities of daily living? Imagine that you are raising a teenager, and your goal is to turn them loose on the world at 18, and they can function alone. They can drive a car, they can wash their own clothes, they can wash their own dishes, they can get a meal together without setting the house on fire, they can remember to eat their meal, they can remember to take their medicine, they have some basic concept of what day it is, so they know if they're supposed to get up and go to work or go to church. Those are your activities of daily living. Can they clean themselves? Can they take a shower? Can they go to the bathroom alone? Can they take care of themselves? Those are activities of daily living, and dementia definitively impacts those activities of daily living, and it only progressively gets worse. So those are things that we really look for. How is this impacting your life? And this is another area where it's really important to know what the baseline was. Because if your life was, I got up, I had my coffee, I went to work, I taught 3 classes, I graded papers, I came home and played mahjong, and then I read a book, and now I can't get up and figure out how to get the coffee pot going, that's a big deal, right? And so something that may seem very simple can be a really complicated thing and a big problem and indicator. So it also can't only occur when the patient is having delirium, okay? So my dad is currently in the hospital at UAB, and a couple of days ago we had a good episode of delirium because he's in his late 70s and had major surgery, and my mom called in a panic, like he's lost his mind. No, ma'am, you've lost your mind. What is wrong? And she says, well, he's doing all these things. I'm like, Mom, it's just delirium. Another thing we call delirium is sundowners, right? It gets dark, we get confused, we're not in the right place, things are a little uncomfortable or difficult, and it takes a minute to reorient. Now, if that's never happened to you, congratulations. I'm in my late 40s, and I will wake up in the middle of the night sometimes and look around and think, where am I at? Okay, this is my house. All right, we're good. I know where I am. Let's get up and get going. You're sleeping, you're dreaming, you're disoriented, and something startles you awake, and it takes a minute to orient. This happens when the patient is awake and a little confused, but that commonly happens when people are sick or out of the ordinary of where they typically are in the day. So that doesn't count as dementia, okay? They have to also have decline, not during that time. The other thing is that it can't better be explained by something else. And we're going to talk about that a little bit, but your doctor, when you come in and say, hey, I'm worried about my mom, she's really beginning to struggle with her memory, your doctor is going to take some time and ask a lot of questions and want to do a ton of tests. And the whole purpose of the test is to make sure that there's not a fixable problem that is causing what you are seeing as a memory problem. And the number one fixable problem that looks like memory loss is depression. So there's a lot of stigma around depression and mental health in the United States and really in the world. Do not get offended when they start asking questions about mom being depressed or dad being depressed or anxious or irritable, which is typically how more people express their depression than I'm sad and crying, is I'm irritable and fussy about all kinds of things. You cannot make a diagnosis of dementia in untreated depression. And I cannot tell you the number of times that we have fixed a depression and the patient's memory is now 100% correct. If you are down in the dumps, anxious and worried, irritable about everything, you can't focus and concentrate, it's kind of hard to pay attention to what's going on around in the world, and you don't really want to, and people don't tend to do so. And so they look like they're struggling with their memory when really what they have is I don't give a crap. And so I could not care less what you are asking me. I'm just ignoring you. It's not that I don't remember. And then it's almost like they realize that saying I don't know irritates you, and they just go right with it. Like we just roll with it. Like if I'm irritated, you be irritated too. So there are some things we absolutely need to rule out. One of those things at all times is depression. Not that dementia and depression can't live together, but they can mimic each other to the point that we have to at least get one under control before we can see what's happening with the other. Go ahead to the next slide. All right, so dementia is not normal memory decline, okay? So we're going to talk about Alzheimer's, which is one of the most common types of dementia, and got the nickname old-timers, okay, because we had to come up with funky names for things, and so it gets the nickname old-timers. Dementia is not normal, okay? I can take you to the nursing home right now, and all of those patients do not have dementia. It is not a normal part of aging. It is a disease process of a progressive decline in memory function and executive function that is not a normal part of aging. However, memory decline itself is a normal part of aging. But memory decline as a normal thing versus dementia as a disease process tends to be easily defined one from another. Memory decline is what I call slow to recall. If I ask you to name all of your children's names, some of you can pop them out like this. Some of you need to roll call, and just like my parents will come up with the wrong list of people's names before you get the right ones, but the right ones come, right? Or, as I always say about my parents and my in-laws, having a conversation, we have the whole conversation with somebody, they walk off, they turn and look at me, who was that? I don't know. I thought you knew who that was. And in a minute, the name will pop up, and they're like, oh, I couldn't remember that name. I couldn't come up with that word, right? In the conversation, I was searching for something, and it just didn't quite happen as fast as I wanted it to, but it did. And they know that it does. That is almost more disruptive to people than actual dementia because they realize that it's slow and it's aggravating and it's frustrating. There are lots of things you can do to work on that so that doesn't happen to you, and we'll talk about those things. Many of those things are the same things that you can do to treat early dementia that you should do to work through that. The patient is aware, it's just slow to come up with the right thing. So I tell everybody to think about it like this. Your brain is a massive filing cabinet, and you have to file all the things that you learned today, get filed when you sleep tonight. And tomorrow morning, when you need those things, your secretary has to run through the files and find it. The more files you put in, the harder it is for her to find. And the stuff you use the least, the further back in the filing cabinet it gets, right? Because she's not an alphabetical girl. She's just shoving it in there as front to back. And so things that you can't recall that take and just pop up in your mind later, words you're not using, names of people, birth dates and things, it's normal for you to forget those things, okay? And have to have some prompting to remember. The other thing I tell people is that multitasking is a lie, okay? It is a lie that we sold to a generation of women to tell them how to raise their children and go to work, but it is a lie, okay? Your brain can do only one thing at a time, okay? Your brain has thoughtful functions and non-thoughtful functions, okay? So right now I'm breathing, my heart is beating, my brain is not having to intentionally tell me to do those things. Those things happen in a part of my brain that work automatically, okay? God, so much smarter than all of us, right, says, look, these people are going to get distracted and they got to breathe on their own or they'll just fall over dead all the time. So we're going to have to help them do that. But the thinking part of your brain requires concentration. So imagine this. If you sit down with your basket of laundry in front of the TV, you can either watch the show or fold the laundry, but you cannot do both. You cannot. You will put the socks together wrong if you don't stop and look at them. What you will really find that you actually do is sort that stuff during the commercials when you're not paying attention, and then you can automatically fold the shirt while you're looking, but they don't all get folded in the same direction. If you didn't pair the socks up already, they don't go well. You really have to actually think about the things that you do. What we should have taught everybody to do was organize. How to make a list, how to keep up with stuff, how to teach yourself how to recall things. That is what we failed to teach and is what we all need to do to maintain our memory over time. A list, a to-do list that's prioritized, a calendar with your appointments on them. You know, I'm always amazed at the number of people that have no calendar and come to their appointments on time. Or they forget, like I forgot that I had this appointment. I'm not shocked by that at all. I don't know that I would have known to come here today if I didn't put it on my calendar. So we need to learn some strategies to help ourselves remember and not depend so much on excellent recall of all things, and that gets worse as you get older or stressed or distracted. That activity gets worse all around. Next slide for me. So we're going to talk about how do you protect your memory. Okay, so if you're sitting here today, your memory works, what do you need to do? You need to read for knowledge. Okay, I like to read for fun. I know, I'm a nerd. That's how you get through med school. I like to read for fun, okay? But you need to read for knowledge. What does that mean? It means you read the newspaper to learn something about what information has happened, or online, not Facebook, because that's not real. But, you know, read some reasonable source of truth for knowledge. You want to do some type of cognitive puzzle, okay? And what type of cognitive puzzle you do has to do with what you like and your baseline cognitive functioning, okay? Do you want to circle the words in a word puzzle? Do you need to do Sudoku and create the math problem and figure out the answer? Do you need to do a crossword puzzle? Whatever you like, a puzzle where there's an answer, okay? Not just, hey, I'm sitting here coloring or whatever, like a puzzle where there is an answer. There are online versions of these, paper versions of these, but what I found in my adult life is everybody is either a math person or an English person. Very few people are a both person, okay? So if math is what you like, then do the math puzzles. If English is what you like, do the English puzzles. Do the word finds and the crossword puzzles. Like the crossword puzzle drives me insane. I don't know the word. I'm never going to come up with the right word. It's not going to happen. Hand me the math and let me do that one. Then you need 30 minutes of physical activity and to eat a heart-healthy diet. Yes, you came to a talk with a doctor, and we're not going to not really tell you the truth, which is the things you eat and the things you do with your body, they play a role in everything that happens to your body. And there's great evidence behind heart-healthy diet, preventing memory loss, daily exercise, preventing memory loss. You should limit the amount of alcohol you drink, and you should not smoke or vape. It is the same thing. So don't do those things. And that really tends to help your ability to maintain your memory over time. Next slide. So let's dig into the types of dementia. I'm not going to read these. I just wanted you to see. Like, these are all the types of dementia, okay? Alzheimer's at the top because it's the most common. Multiple causes at the bottom because we just jumbled all the things together. That's how multiple cause always works. And everybody's favorite prion disease is also at the bottom. That's that fancy mad cow disease or Creutzfeldt-Jakob. Like, that is extraordinarily rare, but it does happen. So, all right, next slide for me. So first we're going to talk a little bit about Alzheimer's. So Alzheimer's is the most common type of dementia. It accounts for about 60 to 80% of dementia cases. Alzheimer's has an insidious onset. Okay, it is slow to develop. It just kind of progressively happens over time. The impairment itself is progressive. It's going to continue to get worse. Okay, so Alzheimer's is a curve going down a hill with your functioning. Okay, you start here, you're functioning well, and over time you're just going to fall down the hill to where you're not functioning. Typically, Alzheimer's presents with a loss of short-term memories first. And this is the thing, like, this is the most common cause of dementia, so this is the thing that you look for. Can you not remember new things that you learned today, but you can remember something that happened 40 years ago as if it happened right now in front of you, okay? So that loss of short-term memory can be really debilitating because people can't remember if they ate. They can't remember if they took their medicine. They don't know if they took a bath or not. They don't remember whether or not the clothes they put on came out of the clean hamper or the dirty hamper, or were those the same clothes they've had on for 3 days, okay? Short-term memory loss is a big problem. The next big problem with short-term memory loss is we are living in the past, a time that does not currently exist, many times with people who do not currently live on this earth with us, and many times with people who weren't our favorite person in the life that previously exists. And so all kinds of things will come out. Now, I will tell you my favorite demented patient when I was a medical student was a pastor. And my favorite thing about him was not him at all, but it was his sweet wife. And she would come outside the hall and sit outside the hall. And he was only in the hospital because he had to have his gallbladder out. So she would sit outside the hall and just cry. And so I sat there one day and I said, "Ma'am, what is the problem?" And she said, "Look, he has dementia." We're like, "Yes, ma'am, we're well aware of that." And she said, "And y'all don't seem to be offended by anything that is happening." And I said, "No, ma'am, we lost being offended a long time ago. Like, it's okay." And she said, "But it is not. His deacons, his church members, they want to visit him because they are good people. And he has been a good pastor, and he is in the hospital. And she said, in his language, I said, it rivals any sailor I have ever heard, ma'am. It is impressive. And she said, don't you see the problem? And I said, I do. It's okay. Like, you don't have to let them visit. We can tell them, I'll put a sign up that says I said they can't visit. That's fine with me. And she said, I just can't imagine what I did that this is how he feels about me. And I said, ma'am? And she said, I mean, when I go in there, he calls me names, he's yelling at me, and I have racked my brain night after night trying to remember what it is I did that he's mad at me about. And I said, oh, no, ma'am. That is not how this works. This is not his true and innate feelings for you that he has held inside for 50 years that he can now just release. That is not how this works. He is confused. This is not personal, and you are not going to do well if you take this personal for the next 10 years of your life. This is not about you. This is about his brain playing tricks on him, and you just have to take it that way. That sweet woman sat there and cried and loved on us, and buddy, she brought us food and was at every visit when she came through because she had truly thought the mean things he said were how he really felt about her. And for the vast majority of dementia patients, that is absolutely not true. This is not their time to confess. They're just confused, and you are aggravating them because you're trying to adult, and you're trying to make them adult, and you're trying to push them to do stuff that they don't want to do, and they don't quite know who you are. Sometimes they do, sometimes they don't, and they just don't respond very well to that. So you really can't take it personally. All right, next slide for me. So, vascular dementia. So vascular dementia is the second most common type of dementia, and vascular dementia is caused by vascular disease. The same things that cause heart attacks cause vascular dementia. So, poor cholesterol, high blood pressure, being overweight, not exercising, all those things. It frequently happens with Alzheimer's. So the two things go hand in hand, and that gets to be one of those multiple dementias that go together. But the difference with vascular dementia is that it is typically of sudden onset and stepwise progression. So instead of rolling down the hill, they have true setbacks where you can see. Here we go. So typically a patient has stroke or a mini stroke, and their mental status is never the same again. And then they stabilize there, right there where they are, and then 3 months, 6 months, 2 weeks, a year later, they have another episode and they fall down the cliff just a little bit more. So it's not a steady, slow progression like Alzheimer's. It is truly like walking down the steps. And once you go past a step, they can't come back. So vascular dementia is a little different. You can imagine if you mix this with Alzheimer's, like it's very difficult because of the stops and starts and spurts that happen here. All right, next slide for me. So, other dementias. Lewy body dementia. Lewy body dementia is hallmarked by fluctuating cognition. So sometimes they know what's going on and sometimes they don't. Not a steady progression of loss, but it is also almost always with recurrent visual hallucinations. They have the same visual hallucination over and over and over again. So, most of you aren't psychiatrists in here, so it's maybe interesting for you to know that typically people with visual hallucinations know they're not real. Like they can tell you that. So we learned in medical school to ask the question, do you see things that you know are not real? Do you hear things that you know are not real? Yes. It is unbelievably disturbing to someone with great cognition, much less somebody with bad cognition, to know that they can't make that stop. Okay, that's something, I can see things that I know aren't right, I can hear things that I know aren't right, and I can't make them go away. My favorite visual hallucinations, the people that live in the ceiling fan. So, you know, families come in, they're really disturbed, and you're just like, hey, tell me what it is you see. Well, there's a guy that lives in my ceiling fan, and when I go to bed at night and turn the lights off and the ceiling fan spins, there's a man that lives up there. Does the man hurt you? No. Okay, good, we're good. If the man hurts you or threatens you, that is not good. That we have to address. Auditory hallucinations, things you hear. If the voices tell you to do bad things or tell you bad things about yourself, There's a problem that has to be corrected. We don't want to go around with some extra voice telling us horrible things, okay? But there are lots of times that people have auditory hallucinations that they know that's not real, and I don't like it, but it's not telling me to do anything bad, okay? So don't be distressed when your doctor starts asking weird questions about you hear and see things that you know aren't real. It's shocking the number of people who can answer that question, yes. Frontotemporal dementia. So this is your exception dementia. This is the dementia where all the mean things you've ever thought really come out. So frontotemporal dementia, the frontal part of your brain is the part of your brain that tells you how to behave socially, okay? It is the thing that made you get up, take a shower, get dressed, put your clothes on because you were leaving the house. Patients with frontotemporal dementia lose that ability, okay? Frontotemporal dementia, to me, is one of the hardest because people become really mean. And they say really mean things to people that they have loved or that they have cared for. And so what happens is they alienate their family and their caregivers because they just think, you know what, my mama, she's just finally telling it the way she's really thought it. She's always loved my brother more than me. She's always liked his kids better. This has always happened. And you know what you do? You don't tell your brother that. Like if you think really deep in your heart that your mama loves your brother more than she loves you, and nobody confronting your brother to say, hey, mama loves you the best. I can't believe you're doing this to me. And so over time, it takes a long time before something bubbles up to the point that both parties realize something has drastically gone wrong. And at that point, you've made a big mess of everybody's life, typically for years, before somebody raises their hand and says, hey, there's something not quite right here. And I thought my mama just didn't like me, but now I realize she doesn't remember me. She doesn't know who I am. She doesn't remember to put on her clothes. You know, my mama was the chairman of the junior league, but she's outside in her underwear in the middle of the day raking the yard. That's frontotemporal dementia, okay? Those patients are hard to deal with. It is a very difficult disease, but it is extraordinarily hard on the family, mainly because they have destroyed their family from within by the time they ever get where they're going. Parkinson's disease causes a dementia. There's Parkinson's-associated dementia. It looks a lot like Alzheimer's dementia, but patients who have Parkinson's disease are highly at risk for dementia. Typically, if they live long enough, they will get dementia. So think about Parkinson's. Those are your patients that shuffle when they walk, like they really walk like that, and they roll their fingers every time they try to do anything. We call it a pill rolling tremor. So those are things we really watch for and look for and know there's a dementia coming with that. Prion disease, you know, my husband's a cattle farmer, so we always get the Creutzfeldt-Jakob, so it's extraordinarily rare. Don't eat the brains of anybody's animals, and you'll probably be okay there most of the time. So I can say that. My granddaddy ate souse and tried to serve it to all of us, and so, you know, it's all good. We don't eat that stuff, and it's all right. Very few things I won't eat. And then those other things that we're looking for in all those labs. Metabolic diseases, infectious diseases, and structural changes. So what do people get offended by when they see their dementia labs? Infectious diseases. One of the things we have to check for is syphilis. Okay, syphilis is an insidious disease. It will rear its ugly head 10, 20, 30, 50 years down the road, and it will cause a dementia, and it is treatable. So we have to be able to know that it's there and fix it. Structural changes. Everybody wants to know when you send them for their dementia MRI, and then you call them back and tell them it's normal. Oh, so I don't have dementia. No, you do have dementia. The normal MRI was what I was looking for. What I want to make sure you don't have is an aneurysm or a brain tumor, something that we can fix, versus there's absolutely nothing we can see on your MRI. Next slide for me. So how do we diagnose dementia? Well, it's just like everything else in medicine. 80% of it is the history and physical exam. You ask questions, you listen, and 80% of the time you know where you're going just by that part. And all the tests and all the imaging is just to confirm what years of schooling and experience have taught you are there. And so we do tests to rule out treatable causes. we do tests to identify biomarkers. And these biomarkers that we are identifying are new. This is something that's happened in the last 2 years. And why is the biomarker new? Because we just figured it out? No. We've known for well over a decade the biomarkers that have been associated with dementia, particularly Alzheimer's dementia. But in the past 2 years, a medication has come on the market that attacks one of those biomarkers. And so we've added that to our baseline workup in the last year or so that we know whether or not the patient has that biomarker and therefore is a candidate for this new line of treatment. So now what I get to do is go back and catch all my patients who I didn't check because their diagnosis was 2-3 years ago and add biomarkers on to their labs and make sure I've checked for this. Yes, ma'am? It's a blood test. It's just in their labs. So typically what I do is add it to their next labs. So we don't do extra tests unless they ask for them, but we're trying to go back and make sure we don't have those. The thing we have to know, and we'll talk about it in a minute, the meds for biomarkers have to be used extraordinarily early in the disease process. So they're not useful late in the process, which is why it is so important to identify early that there's a problem and ask for help instead of waiting until it's so obvious that there's a problem that there's not much else we can do. And then we have that definitive subtyping. So how can I tell you 100% what kind of dementia you have? I can take a biopsy of your brain. Well, that doesn't sound very pleasant, and we don't do that, okay? So when I trained, back when we chiseled out our progress notes on stone tablets, you diagnosed, the definitive diagnosis of dementia was done at autopsy. And it's still done that way to some degree. It doesn't really matter by that point, right? Like all you know then is what patients are at risk for their families. You have to trust the clinical instinct of the person giving you a diagnosis because there really isn't a big test to go take to give you a diagnosis today. Man, I hope it's coming. I hope within the next 10 years we can have that, but it does not currently exist. So, next slide for me. All right, so additional characteristics. There are 2 different things on this slide. So one is severity. We need to know if your dementia is mild, moderate, or severe. So mild dementia is somebody in the early stages of dementia. They can continue to function. They can answer questions appropriately. They are somebody who you would allow to make their own decisions, okay? And that's really important to know. Because if you get to moderate dementia, where their decision-making capacity is impaired and you haven't lined up all the things you need to line up, you are now in a mess. Severe dementia, you don't miss. Patients with severe dementia cannot care for themselves. These are typically patients that live in the nursing home because they require round-the-clock supportive care. They can't remember to take a bath. They can't remember if their clothes are clean. They can't remember to get up and go to the bathroom, so they need diapers, they need food. That is the end stage or severe level of dementia. And then there are additional characteristics. Is your patient with dementia, are they anxious? Do they have behavioral problems? Do they have outbursts? Are they irritable? Why do we talk about that? Because there's medicine for that. Okay, that's actually something we can help you fix. With some relatively new medicine, some of the older medicines that we used for this increase the risk that your patient died. Well, typically that is not our goal, okay? Like we are typically not reaching for that. But at the same time, you have a patient with what is truly a terminal illness and a family who is at the end of their rope. Yeah, we're gonna do the things we need to do. But currently, there are newer medicines to help treat some of these behavioral outbursts that really don't harm the patient, can be super helpful. And why is that important? Because if I can control the behaviors, I can prolong your independence. Right? Because everybody else can handle your behaviors better if we can take you somewhere, if I can go to dinner, those kind of things are really important. You can't take mom to the doctor's office, and now this is real deal. We have patients that'll call and say, hey, we can't let her sit in the waiting room anymore because of the things she says are so offensive that I'm embarrassed. And I'm like, maybe we should go sit in the waiting room and check out what you're saying. But no, we have full empathy, absolutely. You can wait in the car. We have a whole system for that at our office. You can wait in the car, and we'll call you when we have your room ready. You don't get to jump the line or get ahead of anybody else, but you don't have to wait in public, okay? I mean, it can be really difficult, and the behaviors can be as simple as focusing on the same thing over and over and over again. I want something to drink, I want something to drink, and you're sitting there with a glass of water in your hand demanding that somebody hand you something else over and over and over again, to really just saying the craziest stuff that you're like, we can't do this. We can't have them engaging everybody in the lobby in conversation. So really important to understand the staging, really important to understand that the behaviors that come with all types of dementia can be treated. Next slide for me. All right, so what are we doing to treat dementia? So first of all, if we find an underlying disease, we treat it, okay? And then we talk about goals. So where are we trying to go here? What is really important to you? Dementia is a terminal illness, without a doubt. And so we have to really talk about what is important to you. And man, that conversation is a lot easier to have in the earlier stages of dementia. It's also a lot easier to have if it's a conversation that you've had before. So life itself is a terminal illness, okay? There is no guarantee that I'm going to be standing here 2 seconds from now. None whatsoever. I encourage you all to have conversations with your family about what you would like to have done to you if you are alive and cannot communicate, because that is exactly what happens with dementia, but it happens with lots of other disease processes too. Your body is alive, but you cannot communicate because the law in the state of Alabama says that I have to do everything to keep you alive. Everything. Unless you have legally executed a document to tell me this person can make decisions or I only want these things. And let me tell you, I know how I feel, and I have lots of doctor friends, and we all feel the same way. If what you want me to do is hang you upside down and paint you purple, good for you. Could not care less, right? It's your life. Like I have concerns about how you live your life, and I have concerns about where you're going when this life is over, absolutely. But in the moments of the end of your life, what I want is it to be what you want, okay? So whatever you tell me, I will honor. Whether I think it's the right thing or not is irrelevant at that point. My job is to make sure that you pass on in a way that is satisfactory to you. Statistics show that greater than 90% of Americans would like to die out of pain and in their house, not in a hospital, not with a bunch of treatments and medicines, and they wish somebody would have told them 2 years earlier that they weren't going to survive whatever was going on and they would have changed what they were doing. We should honor that, right? We should honor the desires and wishes of people. People who have lived long, happy, healthy lives, they have the right to say, quit doing this to me. Quit doing this to me. So those are conversations that are really easy to have when you can sit at the dinner table, eat, talk, walk around. They are hard conversations to have after hard diagnoses. They have to be had then, but it's extra hard. So I encourage each and every one of you to have that conversation with your family. Don't surprise your family. Those are my least favorite. Where like I've got a document that we executed 10 years ago that says you don't want any of this, and your kids show up and they've never seen the document. So they think I'm some mean lady that taught your mama into doing stuff, right? Don't do that. Talk to your kids. If you have kids that you know should be the decision maker, it's okay to not let them all make decisions. It's all right to say that. So I was my father-in-law's healthcare decision maker. My father-in-law. He has a daughter, his 2 sons and a daughter. But he told my husband, his brother, and his daughter before he died, y'all won't do what I want, and she will. And my husband said, she's never done a thing you wanted. What do you mean? And he said, she's the only one who has what it takes to execute when the time is right. And when the time came, the decisions were made. We did what he wanted to do. And it really gave them a lot of peace to know that that's what he wanted to do, but also to know that they didn't have to make the decision. Because he was right. They didn't want to have to be the one to say, we're done. Just have those conversations. You don't have to let everybody decide. And the person who is legally has the right to decide if you don't have any documentation may not be the right person to decide. My husband would be my legal decision maker. He is not my legal decision maker, not if I am not able to communicate. Because I know what he's going to do. He's going to keep me alive no matter what. And that is not my desire, okay? That is absolutely not it. My son would shove me out of a moving car while I was still talking. He is also not my legal decision maker. My legal decision maker is a friend I went to med school with, whose baby I delivered, who we have stood by each other side by side. We are each other's legal decision makers because we know when the time comes tough, we will handle one another. It will be okay. And that's me. Let me make that be quiet. So, talk about these things ahead of time because this is important. So, what else can you do? So, there are IV infusions for mild stages of disease. And this is where we use these fancy new biomarker medicines. There are only a couple of doctors really in the state that do this. We actually have one in Panama City that does it as well, and so we refer a lot to this area. But you have to be in early stages of disease and otherwise relatively physically healthy because the treatment itself has some real problems that can be associated with it. If you're not really healthy already, it can be difficult to tolerate. The oral medicines, okay? There's two different oral medicines. They can be used with one another, but they are for moderate to severe dementia. Not really severe as much as moderate. Okay, so what are we trying to do with these medicines? None of these medicines reverse dementia. All we do is slow the decline because by slowing the decline, you gain independence longer. Okay, you can stay at home longer, you can interact with your family longer. Those are reasonable goals of care. Other treatments, cognitive stimulation, like let's do something, let's get up, let's be active, let's think, let's interact, exercise, and behavioral therapy. A whole lot of what's going to happen during our respite care ministry. Engagement, conversation, ask some questions. Let's play a game. You know, if I don't quite get the rules right, it's okay. Let's make a craft. If mine's not so cute and it's not going into the art museum, that's okay. Let's just give it a try, okay? Do not isolate yourself from your patients who have dementia. Engage with them. Their answers may not always be grounded in reality, but many times they are, and you can learn some really, really great things. All that stuff is super important. Next slide for me. All right, so what about resources? So let me just say that caregiver support is critical. This respite ministry is truly the hands and feet of Jesus because these family members are at the end of their rope. Like they just haven't gone to the grocery store by themselves with another functioning adult in years. And we all know what that's like when we're dragging toddlers along with us, but this is the opposite of that, right? They need a break. They just need a minute by themselves. So let me tell you, if people come here and they bring their family member for respite care and you ask them what they're doing and they say, I am going to the house and I'm gonna read a book. I'm gonna hide in the parking lot. I'm going to go veg out in front of TV. I'm going to go take a nap. Those are all great things that they really need to be able to do, without a doubt. Now, they may be doing some really awesome, productive things, and good for them. But a lot of times, they just need a mental break, okay? A chance to relax so they can be a better person when they are caregiving for the other 20 hours of the day. You need clear expectations, okay? So, patients who have dementia, there's no real point in redirecting them. Okay? It does not do anything but make them angry and you angry. So why are we trying to correct what they are telling you? It does not work. My grandmother had dementia. She died in the nursing home. She told us that she didn't want to go to the nursing home for a long time, but it just ended up that that was the best option we had, and she was perfectly fine there. It was a better situation than her home. She asked me every time I came when my husband was coming to get her. After I get done cooking supper. Okay, honey, we'll go home. Yes, ma'am. I went home. We had supper. Sometimes he would bring her supper. He would come by and visit. When are you taking me home? Oh, not today. Probably a little bit later this afternoon. It's kind of raining outside. Okay. Out we leave. She was happy. She wasn't anxious. Somebody was coming back to get her when something happened. She could look out the window. Is it raining? Is it cold? Did I cook supper? You know, I got reprimanded a lot of times to go home and cook some supper. And we'd go home and cook some supper. It's okay. There's no point in redirecting and adding to the confusion. It just doesn't help anything, but it is really hard not to do. That is a learned behavior as a caregiver to not do that. You need an elder attorney for legal support. You need all your ducks in a row, because by the time you get to moderate dementia, the patient is really not competent to make decisions, and it's pretty clear. So then they can no longer consent to whatever plan that you created. So before we get to that point, you need dual names on checking accounts, all your names on retirement accounts. You need legal powers of attorney and all your documents executed about healthcare products. All that needs to be executed beforehand, because what you don't want is to be in the situation where you have to have a judge declare your family member incompetent and declare you as the caregiver, and your least favorite cousin from Ohio show up and say, you know what, I've never really thought they did a great job taking care of their mom, and she's my favorite aunt, and I can do better, and so I'll take her and go back to Ohio with her, and then we sit in court and argue about it for days on end, and it happens all the time. So you need good legal documentation of what's going on, everybody's name on all the documents. Then we need respite care, we talked about that, and you need counseling, okay? Whether you go to one-on-one counseling or you join an online Facebook group, if you are a family member, you need to talk to somebody who understands the situation that you are in, because it's difficult. And there are lots of resources for that. I listed some of these here. There are tons of online resources. There are local counselors who specialize in counseling family members of patients with dementia. The VA has dementia resources, so if you are a veteran, take advantage of those resources. You earned them above and beyond. So lots of resources available. All right, that is the end. What other questions do you have? Yes, ma'am.
How does Alzheimer's cause death?
So Alzheimer's itself typically, well, it will eventually cause death, but that's the problem. So Alzheimer's itself causes death in the end because the patient doesn't eat. And so they will just essentially starve themselves to death. It's pretty much exactly what happens. They won't eat, they won't drink, their kidneys will shut down, and they'll starve themselves to death. So for patients who are extraordinarily healthy at the beginning of a diagnosis, that can be a real problem because they're going to live. Typically, the life expectancy of a patient with a dementia diagnosis, they have no other health problems, is 10 years. They have other health problems is somewhere in the 4 to 6 year range, and typically it's not their dementia that causes their death. In that 4 to 6 year range, it's their underlying health conditions. But for patients with Alzheimer's, they either live to the point where they can no longer eat or drink, and you have to make a decision of, are you putting in a feeding tube to keep this person alive who cannot talk to you, have any interactions with you, and that's a very personal decision, or they get sick from something as simple as pneumonia or the flu, and they get an overwhelming infection that their debilitated body can't fight off because they've not ate and drank appropriately for years. So.
Okay, my second.
Yep, let's see.
To say they starve to death, they don't know they're starving.
Not at all.
They don't know they're hungry. They don't know they're thirsty. Families feel really guilty about that.
Mm-hmm.
Put a feeding tube in. But they don't know to eat or that they're hungry any more than they know that they need to eat or drink. Okay? So that families always feel guilty about that. They want to put a feeding tube in. And feed tubes for the family.
Yep.
Not for the patient.
So once again, God is smarter than us. If you don't eat or drink for a little bit of time, you lose the sensation of hunger and thirst. God protects you, and that sensation goes away. How do we know that? By people who have normal cognition, who we withhold food and water from for a variety of reasons. So we know that these patients are not thirsty, they're not hungry, they just don't want to eat or drink anymore. The process of not eating and drinking creates chemicals, a metabolic syndrome in your body that kind of creates a euphoria. So they're just kind of relaxed and happy in their own brain from an eating, drinking standpoint. They may have some pain in other standpoints, but they really don't want to eat and drink. And it is hard to see, and it seems really cruel, but it's really not. Yes, ma'am.
My second question is this anything that's related to modern society? Because I don't remember hearing about, that it's hard for me to verbalize my question, but is this anything that's been, it's a new, we didn't have this diagnosis.
So we did, but we didn't, right? It's not a new diagnosis. I'm going to tell you up front that not eating well, not exercising, sitting in an office every day, all those things are bad on your body and bad on your mind. Absolutely. So do we see more of it because of the lifestyle that we lead? Without a doubt. Without a doubt. But what we did 100 years ago was we took these people and we locked them up and we hid them away. They existed. We just didn't acknowledge that they existed or that they had this problem. And in addition, our life expectancy was not as great. So people died from communicable diseases, things like the flu and pneumonia that you typically don't see people die from now. And so there are a variety of reasons that you see more of it. Extended life expectancy and the fact that we no longer take our people and hide them in the background. We're more open about the fact that my mom's memory's gone and we're really struggling with this.
It's the cardiologist's fault.
It is their fault.
Because you think about all the treatments that are available now. Think about all the treatments that are available. Heart caths, bypasses, stents. There's medicine and procedures now for heart failure. You just don't die of heart disease in your 40s anymore. There are also a lot of cancers that are being treated. People used to die when they were 50 years old from these things. Now you live into your 70s and you get Alzheimer's. And you're exactly right. What we eat, the foods that we eat, we don't grow our own food anymore. Everything we've got is processed. So that has a big part to it.
We also used to call everything crazy, right? Like in the lay world, we use the term crazy for everything that meant that your mentation was not right, from truly lifelong mental illness to I've lost my memory. And we hid those people away, and you just didn't see a lot of it. So it is a word I really dislike using because it's more accurate for my family that has appropriate mental health and just their decisions or what they're doing than it is for patients who are truly struggling with an inability to manage these things on their own.
Back to the biomarkers, is that something you can only see in the blood work once the symptoms have started, or is that something you could do at any stage?
No, you can see the biomarkers in the blood work. The evidence for when those biomarkers present and how severe the disease process is a little up in the air. And why is that? Because in America, we have an insurance-based healthcare system. So the minute I give you a diagnosis that you have a cancer gene or that you are walking around with a p-tau marker that says that you have an increased risk of dementia, you just lost your insurability for life insurance. You no longer lost your insurability for health insurance, but 10 years ago you would have lost your insurability for both of those things. And so in an insurance-based world, there is limited benefit to that knowledge. There's also limited benefit to that knowledge. What are we going to do with it? Like one of the tenets we learn in medical school is don't do things that you don't know what to do the next thing with. Like be 3 steps ahead. So if I know I'm not going to treat somebody, why are we walking down this pathway if now is not the time? And I will once again say, these new biomarker drugs seem amazing, except for the very first one killed so many patients that they snatched it off the market like in a hot minute. So they all have their own problems, and until we've used them universally enough, we don't really know. So it's with the hope, right, is that it's going to be the answer early in the disease everybody pay attention, let's get your medicine, and all's going to be well. But right now, it's not playing out that way.
Those watching online, if you have a question, drop it in the comments, and we will do our best to answer it as quickly as possible as we wait for other questions in the room.
You didn't say what a Lewy body was.
Oh my gosh.
I have my patients say, I got lower body dementia. So, what's a Lewy body?
Lewy bodies are abnormal formations inside the brain that are the cause of the dementia, just like p-tau is what the cause of your Alzheimer's dementia is. It's the thing that is deposited that causes the dementia. And we name all these things after the people who figured it out. That's why it's all named crazy stuff. So.
Okay, so sleep apnea. A person that I know had sleep apnea years ago, and then she diagnosed herself cured and quit using the machine and gave it away. And just recently, she was diagnosed again with severe sleep apnea, and she's getting the machine again. Being that there's already been damage, when she starts using the machine again, could it help in any way?
So the way your CPAP machine is going to help is that you're going to oxygenate when you use the machine, okay? So if you have sleep apnea and you're not using your CPAP machine at night, two things are happening to you, I say at night, whenever you sleep. Two things are happening to you. So one thing that's happening to you is that you are not getting the amount of oxygen that you need all the time that you're sleeping. That in of itself creates some damage. That damage can be somewhat transient. We don't use nearly all of our brain, and so sometimes that can really help. The other thing is once again, God is so much smarter than all of us. And so when you have sleep apnea and you quit breathing in your sleep, you have to wake up to breathe again, okay? And so you're not sleeping really great. That's why patients who have sleep apnea, who treat their sleep apnea with CPAPs, they feel so much better is because they actually got some quality sleep. So there's absolutely some benefit in dementia for giving that quality sleep. You're probably not going to regain function that you lost, but you may absolutely slow the progressive decline of that function. And the number one side effect of untreated sleep apnea is heart attack. So why does your doctor worry all about your sleep and ask all those questions? Because it is a cardiovascular disease risk like no other.
I'm just curious to, I guess, get your opinion on how COVID has affected some of the things that you're talking about. Have you seen any type of onset due to or correlating with COVID?
So not typically dementia. Really, we haven't been far enough past the disease process to see that. There is definitely cognitive decline with COVID that typically can be recovered with time, but that was definitively something that we saw without a doubt, particularly people who did really poorly with COVID, that there was some definitive loss of thought process that took, for some people, 6, 12 months to recover. UAB has a whole clinic dedicated to the recovery of patients who are prolonged after the illness of COVID with continued symptoms and disease. You know, we could spend a whole nother hour talking about all the things that COVID has caused and all the ramifications of that, but it certainly creates some altered mentation, and so in this patient population can be exceedingly difficult. And then you also have the issue of how are you taking care of the family, right? Because you have all these people that don't need a contagious disease, but somebody's got to take care of everybody. So it makes it much more difficult.
So Felicity asked online, what are some helpful strategies when a patient has dementia with sundowners?
Ooh, so sundowners is tough. So number one, don't argue. Doesn't help anything, just makes everybody mad. Number two, as much as you can be consistent at that time of the day, it can be really helpful. So, you know, That's not the time to go to the grocery store, to have to go get our hair cut. Like, those are things we need to do in the morning time of the day, so that where we are in the afternoon is pretty consistent. That really seems to help a lot. Know it's coming, right? It's like a kid with colic that you know is going to have a witching hour from 6 to 7. You know, you just know it's coming, and you be prepared. As much as you can be relaxed, anticipatory that this is going to happen, and not let it spin you up, the better off you're going to be in dealing with that situation. But I got tickled. I have a cousin whose mom died with Alzheimer's several decades ago, but not taking people to the grocery store is one of the things I learned from him, because he realized real quick, like when we're in the middle of the grocery store and all of a sudden Mama is yelling at the other people, who is this guy and why are you letting him leave with me? And he was like, she came with me, let me put her in the car, we got to go home. So, you know, just try not to get out of your set environment. We all like our comforts and like to realize and know where we are. Mm-hmm.
UTIs. Can you kind of explain the whole UTI aspect of it?
So UTIs mess up everybody's mental status that are over the age of about 65 in general. I mean, they get confused. Any kind of infection does it. UTIs are just super common. And so you're sick, you run a fever, you get irritable. Okay, my mentation's good. I know that's what's going on. But if my mental status is not at baseline and I get sick, then it's going to make all of that worse. So we get more confused, we get really altered, we get irritable. So number one reason for show up in the emergency room, patient complaint is Mama's confused. First thing out the gate, your ER doctor's going to check your urine, because if they have a UTI, that is a very fixable cause of confusion. But it is a common cause of confusion even in patients without dementia. So it's one of those metabolic causes of memory loss. Jen has a question.
So what are some of the medications you can use when they're advanced and like they have the behavioral issues?
So behavioral medicines now tend to lie essentially in the realm of dextromethorphan cough syrup. So old school cough syrup that we used to use has been shown to modify some of those behaviors. And so it's a real high concentration of it given in a pill. We don't just hand out cough syrup and say, hey, this is what we're doing. But it doesn't cause an increased risk of death and has been really imperative, just really been impressive to see how well it has altered some behaviors. Altering behaviors are important when you live at home with your family. They're also really important when you live in the nursing home, right? Or when you have to pay for a caregiver, because you don't want to run off all your caregivers, and you don't want to disturb the whole nursing home, and every time somebody comes around, they're having to send you to the hospital for something. So the newer medicines tend to live in that. Old medicines are the old school antipsychotics, the sedatives, those kind of things. The problem is a lot of people have the opposite reaction to those things, and so it can make it worse instead of better. Trial and error. You don't always know until you do it, but the old antipsychotics that we would use, and that we still use for true psychosis tend to increase the risk of death in patients with dementia, and we don't really know why.
Say that again now. The what?
The old antipsychotics that we still use for real psychosis, they tend to increase the risk of death when we use them for behaviors in patients with dementia, and we don't know why.
So what do you recommend then?
So what I recommend is that we have a goals-directed conversation that says, would you rather have Mama relaxed and increase the risk of her death, or keep Mama alive for twice as long, but she's going to behave like this every day? And there's nothing else we can do to change those two things.
I sort of have a bias that giving medicines like Ativan always make dementia worse.
Always.
It gets the opposite effect. And then, now you're saying that my favorite drug, Haldol, and Thorazine will kill them.
Yep. They carry a black box FDA warning for that.
Oh.
Yeah.
Maybe I should read
Don't read the label. Don't read the label with all that black box warning on there. Yeah.
Okay. What about Geodon?
same. All antipsychotics carry the black box warning.
Oh,
Everyone.
so, all right.
So, tend to stay away from Ativan. You know, Ativan is a good long-acting antipsychotic, anxiolytic, which is great in adults because it decreases the likelihood of addiction. It is not so great in patients with dementia. Like a little bit goes a long way. It's nicer to have something that wears off a little faster so that you know whether you did good or not. If they can tolerate it, it's fine.
If somebody's in hospice, can they receive all this medication for
Yes.
Alzheimer's?
Absolutely. So if somebody's in hospice, they can absolutely receive any medication that is the purpose of which is to create them to have a safe and comfortable life. So none of the medicines work in end-stage Alzheimer's. So there's no point in them. So there's also no point in your cholesterol medicine. There's no point in all kinds of medicines at the end stages of Alzheimer's. And so we have to have real conversations about why are you making mama eat this handful of pills? Like, what are we trying to do? We treat cholesterol for 10-year prevention. We do cancer screenings for 10-year prevention, not today. So when you have a terminal illness, we should have logical discussions about whether or not we want to continue to do those things. And everybody feels differently about it, but we should have discussions that are based in facts. What are we trying to do? What is the benefit of what I'm doing, and what is the risk? You know, and the risk is you take a patient who already has dementia and you take them to the hospital and put them to sleep to do a biopsy, and you advance the disease 5 years overnight. And we know it happens every day. So, but yes, hospice covers all kinds of things that make your life more comfortable. Look, I'm a big proponent of hospice. We don't call hospice early enough, and we don't call hospice often enough. The data shows that if you call hospice at the appropriate time, earlier in all disease states that are terminal, the patients live longer and have a happier life, and the families are happier. It's a very, you know, it's the opposite of what you would expect, but it is absolutely the truth. If we quit dragging you around to the hospital, we quit putting you through a bunch of tests, people tend to settle, live longer, be more comfortable, be happier. So I'm a big proponent of hospice.
Okay, so I'm really big in supplements. I like the homeopathic route on things, and I'm currently like using different types of magnesium. 3 of them: magnesium glycinate, threonate, and taurate at night to sleep. What are other supplements that you know of that you would suggest? And then also sauna. Is a sauna good for a patient with dementia?
So I don't think a sauna is going to hurt a patient with dementia. You do have to worry about dehydration and be real careful about that. You know, there is no current evidence of any benefit of any supplements that I am aware of for the treatment of dementia. It is a terminal disease, and you're not hurting anything. You may not be helping anything. That is a very personal decision. But if we're looking for things that have evidence where I lined up 100 people and I gave 50 of them one thing and 50 of them something else and could tell a discernible difference in how they did, that doesn't exist. So.
The sleep apnea thing kind of made me curious. So you're saying if you don't treat sleep apnea, that could lead to dementia? Or?
So untreated sleep apnea definitively leads to heart attacks and strokes, which is then that's the subset of vascular dementia. So yes, ma'am.
Okay, thank you.
The other thing that leads to dementia is using sleeping pills. So the other thing that leads to dementia is the use of sleeping pills. So prolonged use of what most people would call sleeping pills, what we call sedative hypnotics, Ambien, Lunesta, you know, those medications have clearly been shown to increase your risk of dementia. Tylenol PM, yeah. Benadryl is not meant to be your friend on daily use. I know. Why? Why? Because of your bladder, all the effects that Benadryl has. It should not be a daily. That's the reason Claritin exists. Just nightly, not daily, huh? Just nightly. So melatonin has never been shown to increase the risk of dementia and can definitely help people with insomnia, without a doubt. The dosing is difficult to figure out, different for different people, but it does not have the same risk as the sedative hypnotics. Melatonin, yeah. So, but it's also not been studied for 30 years like the sedative hypnotics that we use for sleep. Those are meant for occasional use, not nighttime, every day for years on end. So.
Okay, let's give a round of applause for Dr. Jordan. Thank you so much. Thank you. Is it okay for us to share these slides with everybody? This is what I'd like you to do. If you've got a cell phone, just go ahead and pull it out, and you can send me a text to 334-400-4298. 334-400-4298. Send me a text with your email, and I will email these out tomorrow, okay? And that way you can have them. I know some folks were taking pictures, but we can release that. Again, that number is 334-400-4298, and I will send those out to you. Just make sure to send your email and all the right spellings and caps and all those things so it doesn't mess it up, okay? I used to work in a library, and we would make fun of everybody's emails, so nothing, just like nothing will offend a doctor, no email thread will offend me, so don't worry about that. All right, well, seeing that there's no questions, I'd like to just close us in a word of prayer, and what I'll also do is in that email to you, I'll include information about our respite care so that you can have that as well to share with your loved ones or for yourself, and you can use that as a resource for you as well. Let's go to the Lord in prayer. Father, we're thankful for all you do for us, and Lord, we are thankful that you are omniscient. You are all-knowing, and you made us in such a way that we are so unique among all your creations, and for that we give great thanks. But as we know that there are things that just seem to happen, dementia and others that sometimes have root causes and other times are just terminal diseases that come about, and we pray for healing. We pray for wisdom to continue to learn how to treat and how to provide great care. And for all those that are gathered here tonight, I pray for them and their families that you be with them and that they know they have a space here at First Methodist Church that loves them and cares for them and wants to continue to find ways to provide excellent care for them and their families, spiritually and socially, in ways we can offer events like this. Be with us in Jesus' name. Amen. All right, friends, that concludes everything this evening. You're more welcome to go. Again, if you need the restroom before you leave, this door to the right or that door to the left. It's along this hallway here.